We all know that a long-standing nutrition concern across the globe is excessive intake of added sugars. Over 90% of North Americans exceed the recommended limit for added sugars in the diet, and this has been the case ever since a limit was defined. As a result, consumers and practitioners need practical and well-accepted tools to reduce the intake of added sugars, and one of these tools is low-calorie sweeteners. Although a variety of these sweeteners have been approved as safe by global regulatory authorities, there's continuing confusion around whether or not low-calorie sweeteners are in fact a reasonable option for replacing sugars. Our objective today is to promote the understanding of how the safety of low-calorie sweeteners is evaluated by authoritative groups, how we can apply this knowledge, and then finally, we'd like to provide you with messages that can be used in your nutrition or your healthcare practice. By way of a little background about the organizations that are bringing you this today, ILSI North America is a nonprofit scientific organization that advances the understanding and the application of science related specifically to the nutritional quality and safety of the food supply. This organization operates under a tripartite model, and you can see that icon to the left of your screen there. The idea being we bring together scientists from these three sectors to work cooperatively and provide science that improves the health of the public. Important to note is that ILSI North America does not lobby, conduct lobbying activities, or make policy recommendations. And here you see the core values of the organization. I'll just put these up here, but if you would like to learn more about how we incorporate them into our work and in the research we support, please feel free to visit the website you see at the bottom there, www.ilsina.org, and you can find out more about the organization. And we're working with the American Association of Clinical Endocrinologists to bring you the information today. And as outlined here, AACE serves as the trusted voice for practitioners that work in healthcare and that specifically treat individuals with endocrine-related conditions. And you can see here the mission and vision of the organization. The mission is to enhance the ability of members to provide the highest quality care for patients. And then the vision of AACE is to be the most recognized, valued, trusted, and respected among organizations of its kind. All right, welcome everyone. I think we can start. Hopefully we'll have a few more people join us. I want to make sure everybody can hear me all right. Okay, and welcome again. Today we are holding this webinar focusing on reducing added sugars content of the diet with a focus on low-calorie sweeteners. My name is Marie Latulippe, and I'm staff of ILSI North America. And ILSI North America has collaborated with the American Association of Clinical Endocrinologists to bring you this webinar today. Just a quick note that we would love it if everyone would just mute your phone. All you need to do is click on the icon through GoToMeeting. That is either, okay. Example, click on the icon that's either a microphone or a phone, and that should take care of it. So to give you a little bit of background on the topic for today, we all know that a long-standing nutrition concern across the globe is excessive intake of added sugars. Over 90% of North Americans exceed the recommended limit for added sugars in the diet, and this has been the case ever since a limit was defined. As a result, consumers and practitioners need practical and well-accepted tools to reduce the intake of added sugars. And one of these tools is low-calorie sweeteners. Although a variety of these sweeteners have been approved as safe by global regulatory authorities, there's continuing confusion around whether or not low-calorie sweeteners are in fact a reasonable option for replacing sugars. Our objective today is to promote the understanding of how the safety of low-calorie sweeteners is evaluated by authoritative groups, how we can apply this knowledge, and then finally, we'd like to provide you with messages that can be used in your nutrition or your healthcare practice. By way of a little background about the organizations that are bringing you this today, ILSI North America is a nonprofit scientific organization that advances the understanding and the application of science related specifically to the nutritional quality and safety of the food supply. This organization operates under a tripartite model, and you can see that icon to the left of your screen there. The idea being we bring together scientists from these three sectors to work cooperatively and provide science that improves the health of the public. Important to note is that ILSI North America does not lobby, conduct lobbying activities, or make policy recommendations. And here you see the core values of the organization. I'll just put these up here, but if you would like to learn more about how we incorporate them into our work and in the research we support, please feel free to visit the website you see at the bottom there, www.ilsina.org, and you can find out more about the organization. And we're working with the American Association of Clinical Endocrinologists to bring you the information today. And as outlined here, AACE serves as the trusted voice for practitioners that work in healthcare and that specifically treat individuals with endocrine-related conditions. And you can see here the mission and vision of the organization. The mission is to enhance the ability of members to provide the highest quality care for patients. And then the vision of AACE is to be the most recognized, valued, trusted, and respected among organizations of its kind. Just to note that as we go through the webinar today, you should feel free to type any questions in the chat box, and you'll see at the bottom of your GoToMeeting icon, there's the word chat. So you can enter your message there, and if you can either by default send it to everyone, or you can select here to send it, for example, just to the organizer. And a quick outline of what we'll cover today. We'll have an overview of the FDA safety evaluation procedure. We'll hear about the AACE position related to the use of low-calorie sweeteners. We'll learn about a specific project that evaluates the application of the ADI in nutrition research. And then finally, we'll give you some ideas about how practitioners can use that information. So with that, we'll go to our first speaker, who is Dr. Juen Anyangwe of the US FDA. And Dr. Anyangwe is a regulatory toxicologist in the Office of Food Additive Safety. And there she evaluates the safety of direct food ingredients. Dr. Anyangwe is a multidisciplinary scientist with education and experience in many areas: biochemistry, nutrition, cancer biology, molecular biology, nutrition, and toxicology. And Dr. Anyangwe also has over 18 years of higher education experience. So with that, I will hand the platform over to Dr. Anyangwe, who will provide an overview of how food additives, which include low-calorie sweeteners, are evaluated for safety. Dr. Anyangwe.
Thank you, Marie, for that kind introduction. It's indeed a pleasure for me to share with you today how the FDA conducts safety evaluation of food additives before they go to the next slide, please. So this is my disclaimer. The opinions and conclusions expressed in this presentation are solely my views and not necessarily reflect those of the Food and Drug Administration. Next slide, please. So the Food and Drug Administration has a mission to promote and protect public health. So the agency ensures that the nation's drugs, food supply, including dietary supplements, medical device, biologics and cosmetics, as well as tobacco products are safe for people to use. Next slide, please. So within the FDA, there are several centers. One of the centers within the FDA is the Center for Food Safety and Applied Nutrition. And within that center, there is an office called the Office of Food Additive Safety. That's the office I work in. And that office has the authority to regulate all ingredients added to food. So the mission of the OFAS is to protect and enhance consumer health by ensuring the safety of substances that are added to food and any substance that comes into contact with food. Next slide, please. So what gives FDA the authority to regulate food additives? It's an amendment to the Federal Food, Drug, and Cosmetic Act that was done in 1958, called the Food Additive Amendment Act. And in that act, food additives are defined in Section 201S. A food additive means any substance, the intended use of which may result or reasonably be expected to result directly, indirectly, it becoming a component of food, or otherwise affect characteristics of any food. This definition definitely includes things that will come in contact with food in the production, processing, treatment, packaging, and transportation of food. So we have basically two kinds of food additives, those that are added directly, that are done intentionally, and those that might come in contact with food indirectly. So there's no intention, but then you could have it in contact with food. Next slide, please. So the additives I want to really focus on in this presentation are the direct food additives, and these are some categories of direct food additives. If you had some you may have you may have used some sweeteners, preservatives, nutrients, fat substitutes, texturizers, and flavoring agents. So these are examples of some direct food additives that the FDA does regulate. Next slide, please. So Section 409 of the Act says that for a food additive to go into the market, it has to be shown to be safe. And what really qualifies a food additive as safe? A food additive is said to be safe if there is reasonable in the minds of competent scientists that the substance is not harmful under the intended conditions of use. And the safety standard for food additives is called reasonable certainty of no harm. Reasonable certainty of no harm is the safety standard for food additives. And the burden really of proof is on the petitioner. So the petitioner has to assemble and present to the agency in the form of a petition all data that is relevant to support the safety of the ingredient, and even data that doesn't support the safety. So they don't have to pick and choose the data to submit. So they have to submit everything that is relevant to the safety of that food additive concerning the intended use of the additive. Next slide, please. I want to share with you a provision in this clause called the Delaney Clause. The Delaney Clause says that the FDA cannot approve the use of any food additive if that food additive is shown to cause cancer in animals or humans. If there is an experiment out there that shows that a food additive causes cancer in animals, then the FDA is prohibited from approving that food additive. And this clause applies just to the food additive. It doesn't apply to any constituents or impurities of the food additive. Next slide. So how do we conduct safety evaluation of food additives? It's basically a requirement process. So we have a toxicological assessment of the data coming from studies, experimental studies. We also have an exposure assessment where we look at how much people are consuming of that ingredient. So the exposure assessment is typically done by a chemist who calculates what we call an estimated daily intake, an EDI, or they calculate what we call a cumulative estimated daily intake. So that's done by the chemist. The toxicology piece is done by somebody like me who is a toxicologist, where we look at the data coming from animals or humans sometimes. We look at the hazard, characterize the hazard, and from that we determine what we call a point of departure. And from that point of departure, we calculate what we call an acceptable daily intake. So now you have an EDI from the exposure assessment, you have an ADI from the toxicological assessment. Then you have to characterize the risk, because remember, if there is a hazard to anything and there is no exposure, there is a risk. So you have to calculate the risk. So it's basically a risk assessment process where we do evaluate the safety of food additives. Next slide, please. So these are some of the data that we receive in the package. So if you look at FDA Red Book 2000, it provides you with some of the guidelines or recommendations for how to conduct some of these studies. So typically we would receive a subchronic study, meaning a study that's done in rodents or non-rodents for 90 days. Sometimes we do receive chronic studies and cancer bioassays. We also receive what we call the ADME data, absorption, distribution, metabolism, and excretion of that food ingredient. Genotoxicity, does the ingredient cause damage to DNA? Developmental and reproductive toxicology data, carcinogenicity data, and sometimes based on the signals that we get from some of these studies, and also based on the nature of the ingredient, we might request neurotoxicity data, endocrine disruptor data, immunotox data. And if it's a protein, then we'll expect
focus. Move offers individual tailoring to meet your needs.
Can somebody mute their phone, please? If it's a protein, then we would expect them to also share with us some allergenicity data. And we do sometimes receive human studies because these are food additives. We don't get robust clinical trials like you do for drugs. However, we do receive what we call human tolerance studies. These are usually short-term clinical studies where they look at the absorption of the compound, distribution, metabolism, excretion, and any adverse effects that could occur in humans. And if you want to determine a study, that's your pivotal study, that study must be done under good laboratory practices, and the full study report must be submitted to the agency for review with all the raw data. Next slide, please. And sometimes we might have to call upon other scientists who have expertise to help in the review process. For example, if you have a two-year cancer bioassay, we'll probably need a pathologist. So we'll consult with a pathologist to help us analyze the data. And sometimes we'll need the help of a statistician, a medical officer, microbiologist, or molecular biologist, depending on the nature of the ingredient and the kind of data we are looking at. Next slide, please. So from the toxicology studies, we now determine what we call the point of departure. And the point of departure is actually a point on a toxicological dose response curve established from experimental data or observational data that corresponds to an estimated low effect or no effect. So one example of a point of departure is what we call the no observed adverse effect level. This is the highest dose at which there is no observable adverse effect. So let's say you have 4 doses, and at the highest dose, you start seeing changes in liver enzymes, liver weight. So
and with that, we'll move to our next speaker, where we'll hear about the view of the American Association of Clinical Endocrinologists on low-calorie sweetener safety and the utility of low-calorie sweeteners as a tool. And with that, I would like to introduce Dr. Brij Makar, who is a leading senior diabetologist and obesity specialist in India. He's been an active member of the Indian Medical Association right from the beginning of his career. Dr. Makar is a member by invitation to the American Diabetes Association, and he's a member of the Canadian Obesity Research Network. He's also a fellow of the Royal College of Physicians in the UK and a fellow of the American College of Physicians, as well as a fellow of the American College of Clinical Endocrinologists. Dr. Makar still takes time to offer free and subsidized care to many patients in his clinic and in the community. With that, I'll turn it over to you, Dr. Makar.
Thank you, Marie, and good morning, everyone in the audience. My job has been made much simpler by Dr. Anyangwe. She has given a very beautiful overview of how the acceptable daily intake and the estimated daily intake are important, and how they are defined, and that the ADIs are very safe levels. What I'm going to do here is to give you a brief overview of the ACE viewpoint on this subject of using tools, of using low-calorie sweeteners as a good tool for helping weight maintenance and diabetes. So can we move on to the first slide? I don't have any conflict of interest here. Next slide, please. The context of this presentation is, Dr. Anyangwe has already set up the context very nicely, but I'll briefly, tell you what is the context. We know that large number of North Americans consume excess sugar, much more than what is generally recommended for daily intake. And there is very big concern of increasing prevalence of obesity and type 2 diabetes, not only in America, but across the globe. Now, low-caloric or non-caloric sweeteners appear to be a logical and viable tool to help reduce excess sugar intake. And the available sweeteners that are there in the market are all approved by FDA for use, and they have been labeled safe. Now, despite all this, despite the safety, label from the regulatory authorities, there are still a lot of safety concerns about the use of low caloric sweeteners on a regular basis and on long-term basis, because they are being consumed in day out for many years during the lifespan. So this interferes with their potential use in helping reducing blood sugar levels or in reducing weight or maintaining weight of the patients who are overweight or diabetes patients. Can we move to next slide? So what are low caloric sweeteners? Low caloric sweeteners are commonly termed as non-caloric sweeteners also, or non-nutritive sweeteners, or artificial sweeteners, or I recently found a word called high-intensity sweeteners. They are basically sugar substitutes, which are not sugar. They are sweeteners, and they can be used instead of regular table sugar. So what they do is they give you sweet taste without giving you calories, and they are commonly found in a variety of foods or drinks which are labeled as diet or sugar-free foods or drinks, commonly used diet sodas or low-cal foods which are available in the market. Next slide, please. Now, low-caloric sweeteners offer sweet taste but lack calories, so they are offering calorie-free sweet taste. Now, important thing to understand here is that their sweetness intensity is much more as compared to common sugar. So they are much more sweeter as compared to common sugar. So very small amounts are required to produce sweet taste. And we have already seen the list of approved sweeteners in the previous presentation. The commonly available sweeteners, saccharin, acesulfame, aspartame, neotame, sucralose, advantame, everything is, they all are FDA approved and they are safe. And FDA has approved also one natural sweetener which is obtained from plant. Now, it is not exactly a natural sweetener. It is a processed sweetener, but it is processed from a plant extract or plant leaf extract, which is called stevia. Next slide, please. Now, FDA, as we have already, listened to Dr. Anyangwe, has established acceptable daily intake for each approved artificial sweetener, and this is a very safe dose. Acceptable daily intake is the maximal amount which is considered safe if consumed every day over the course of a lifetime. So these ADIs are set at a very conservative levels, and if the estimated daily intake or cumulated estimated daily intake is less than the ADI, then FDA approves the additives or sweeteners as safe and safe for long-term consumption. Next slide, please. So, what are the potential benefits of these low-caloric sweeteners? I think have very important potential benefits in management of weight and diabetes because they just give you taste without giving you calories. So, uh, once you are using them in place of sugar, you can actually cut down the calories significantly. A bottle of soda usually has something like 150 to 160 calories, while if you are having a diet soda, it doesn't have any calories. So people who are consuming more than 2 or 3 sodas on daily basis, which are sugar which have the sugar, they're consuming something like 300 to 400 calories from these drinks. But if they are taking only sweetened drinks with low caloric sweeteners, they can significantly cut down the intake of sugar and calories, and this can help them lose weight or maintain their weight and help them preventing regain from weight loss if they have lost weight or maintain their weight where they are. Similarly, in diabetes, these low caloric sweeteners, since they are not carbohydrates and they don't have calories, they do not lead to postprandial or post meal excursion of glucose levels. So they can help diabetes patients to have sweet taste, which is commonly these patients crave for because this is prohibited for them kind of, and they can still have the taste without disturbing their sugar levels. Another potential benefit is since they are not sugars and no carbs, so they don't contribute to tooth decay and cavities. Next slide, please. While there are potential benefits, there have been some concerns about the use of low caloric sweeteners, and the most important has been that they may cause cancer. Now, my previous speaker, Dr. Anangwe, clearly showed that they can't approve there is a Delaney clause, and they don't approve any, food additive if there is a potential risk of cancer. Now, why this notion still persists is because the experimental studies way back in 70s linked saccharin to some bladder cancer reports, but now it is very clear, and the National Cancer Institute has also given a clarification that there is no sound scientific evidence that any of the artificial sweeteners or low caloric sweeteners approved for use in United States cause cancer or any other serious health problem. And numerous studies have confirmed that artificial sweeteners are generally safe in the limited quantities, that is, if they are taken within the acceptable daily intake range, and they have been shown to be safe even in pregnant women. Next, please. Next slide, please. Yes. Another possible concern is that people who are consuming low caloric sweeteners actually are not able to, take advantage of reduction in calories with their usage because they may take extra calories from other sources, which is kind of replacement of calories coming from alternative, sources of food. What happens is once the person is consuming a diet drink or low caloric sweetener added to food, the person in the back of mind has that feeling that I am cutting down on calories. So, they don't feel the guilt if they are consuming extra calories from other foods. So it's generally commonly, you will see in the eateries that people are having a diet coke and they are having a big pizza. They are not concerned about the calories that are coming from pizza, but they are cutting down calories from diet coke. So it is not just consuming the low caloric sweetener or drinks or foods with the addition of low caloric sweeteners. It is the overall caloric intake which is important, and that feeling that you are cutting down calories at times leads to increase in the replacement of calories from other sources. In fact, one of the large studies, which is a multi-ethnic study of atherosclerosis, the study showed that daily consumption of diet drinks was associated with 36% greater risk of metabolic syndrome and 66% increased risk for type 2 diabetes. Now, it is not necessarily that this increase in risk was because of the consumption of diet drinks. Possibly the people who were taking these diet drinks were also consuming extra calories from other sources. So we don't know that. So education, counseling, behavior therapy, all these are important, you know, uh, tools which are helpful in helping the patients to have judicious use of low caloric sweeteners. Next slide, please. There is another concern that ongoing use of low-caloric sweeteners may cause a dissociation between sweet taste and calories and may prevent individuals from associating the sweetness with calorie intake. Normally, once you're consuming a sugar drink, you know that you're consuming calories. Now, since you are consuming only low-caloric sweeteners, you feel that sweet is not calories. So you may end up consuming the hypothesis that people who are consuming a lot of low caloric sweeteners may eat foods which are sweet and have calories, but they, on the back of mind, they are not registering that they are consuming more calories. They're just consuming sweet. And this dissociation can lead to, you know, craving for more sweets or choose more sweet foods over nutritious foods and may lead to actually weight gain. Another study, which was San Antonio Heart Study, which was again big study looking at the cardiovascular risk, showed that people who drank more than 21 diet drinks per week were twice as likely to become overweight or obese as compared to people who didn't drink diet soda. Again, you know, the question is whether these people are consuming calories from other sources is important. It is not just that they are consuming less calories from sugar. And there are some animal studies which suggest that artificial sweeteners may be addictive, but nothing has been validated. Next slide, please. So, however, there are these concerns that these concerns have not been validated by any large studies. Next slide, please. So we know that low caloric sweeteners are, you know, good substitute for sugar. They can help reducing calories and carbohydrate drink. There is no clear evidence as of now supporting that they are effective in helping weight loss and maintaining weight, you know, at a lower level or avoiding weight regain on long-term use. So they may be helpful. Potentially, they can help in reduction of calories. They can help, you know, along if they are consumed in conjunction with diet education and behavior therapy. They should be helpful in losing weight and improving diabetes control also. But whether they are helpful on long-term basis, we do not have much data. And we do not have data that there is any difference in health outcomes in patients who have been regularly consuming low-caloric sweeteners versus those who are not consuming low-caloric sweeteners. Next slide, please. Now, another important thing is that recently we have got some studies which show that all these low-caloric sweeteners may not have similar effect in body. And the studies have shown, a recent study showed that some of the sweeteners can cause weight gain while the others can cause weight loss. Now, this was an interesting study published recently in American Journal of Clinical Nutrition, where 4 different sweeteners were given to the volunteers for 3 months in the daily acceptable dose intake. So they were not consuming, less than average acceptable daily intake because they've uniformly given the acceptable daily intake on daily basis for 3 months. And at the end of 3 months, the study showed that while sucrose and saccharin consumption was associated with weight gain, sucralose consumption showed decrease in energy consumption and weight loss. So possibly we don't have a full understanding of uh, how these low caloric sweeteners work as of now, and possibly we need to have more studies to give us understanding, because till now we feel that if it is a low caloric sweetener, it works by and large the same as the other one or third one or fourth one. Next slide, please. And if you look at these studies from large epidemiological or observational studies and results from the intervention studies, the results are conflicting. While on one side, the observational studies have reported an association between low caloric sweetener consumption, weight gain, unfavorable metabolic and health outcomes, the studies, which are the interventional trials, have shown that low caloric sweeteners may be helpful in weight loss, especially when used in conjunction with caloric restriction for intentional weight loss. So possibly we need more, human studies to determine the effect of low caloric sweeteners on weight, metabolism, or chronic disease. These studies need to be conducted in a manner that closely reflects their use in real life. It reflects how they are consumed in real life and what is the impact of that consumption on these outcomes. Next slide, please. So to sum up my presentation, I would say that low caloric sweeteners may be consumed in food or drink daily as part of a healthy diet. Low caloric sweeteners may be useful alternative for people with diabetes who need to watch their blood sugar levels while still enjoying their favorite foods which are sweet. So basically they can get sweet taste without getting additional calories. Low caloric sweetness may be helpful in lowering overall number of calories consumed, which may be helpful in achieving and maintaining healthy body weight and thereby lower the risk of heart disease and diabetes. Next slide, please. For those who consume sugar-sweetened beverages regularly, a low-calorie or non-nutritive sweetened beverage may serve as a short-term replacement strategy. Education, counseling, behavior therapy, they are all important to help judicious use of low-caloric sweeteners and curtail overuse of low-caloric sweeteners. However, we still need more human studies and possibly in a manner that is reflective of their routine usage in daily life uh, to clearly define the role of low-caloric sweeteners in management of weight, metabolism, or chronic diseases. Next slide, please. With this, I think I have come to end of my presentation. Thank you. And if there are any questions, I'll be happy to take.
Great, thank you, Dr. Makar. We'll go to our next speaker, Dr. Jennifer Vandelite, and I will just open your presentation here, Dr. Vandelite. We'll speak about how the ADI, the metric that was mentioned by both previous speakers, is used in scientific research. And this is important because this research often forms the basis of professional practice guidelines. By way of introduction, Dr. Vandelite has an extensive background in animal feed and human food production, in nutrition, safety, and regulations, with academic, industry, and global perspectives. Her research and experience spans areas from consumer packaged good labeling compliance all the way to basic research. In addition to being a senior consultant with ToxStrategies, Dr. Vandelite is an associate professor at the University of Minnesota College of Veterinary Medicine. She's the director of the Integrated Food Systems Leadership Program, and she's also the co-director of the Food Protection and Defense Institute, which is a Department of Homeland Security Center for Excellence. With that, I will turn it over to you, Dr. Vandelite.
Thank you, Marie. Next slide. So in way of disclosure, ToxStrategies is a private company, and this work that we're going to talk about was commissioned by ILSI North America. There are additional disclosures for the individual co-authors provided in the protocol that can be found on the Open Science Framework. Next slide, please. So when we first started working with ILSI on this project, one of the overall objectives was to create a resource for practitioners and public health professionals to provide information to support the safe and appropriate use of low-calorie sweeteners to achieve nutritional goals. So one of the reasons that this came about is because in nutrition research studies, we really needed to understand more clarity about how daily intake levels of low-calorie sweeteners in human populations are assessed in the context of ADIs. So our previous speakers this morning talked about ADIs and how they're derived by authoritative bodies like FDA. And this work is really looking at how those ADIs are used in research to talk about daily intake levels. So the way we did that is we first looked at literature that is comparing intake values of ADIs. Those ADIs could be derived by the European Food Safety Authority or JECFA, the international body, or FDA, and then evaluating the application of those ADIs within this literature database and publishing those findings. Next. So what is an appropriate use of an ADI? So an ADI, or an acceptable daily intake, is defined as the amount of a substance, it's expressed on a body weight basis, considered safe to consume daily over the course of a person's entire lifetime. It's applicable to the general population and includes all age ranges and physiological states. This age range and physiological state include children over the age of 3 months, teenagers, adults, the elderly, and pregnant and lactating women. Most importantly, though, the ADI is not intended to serve as a threshold of safety for a moment in time or a brief period in one's life. Next slide. I do want to thank my team. I get the privilege of presenting the webinar to you today, but without this team, this work truly would not be possible. It is a multidisciplinary team. Many of the scientists at ToxStrategies, toxicologists, and additionally, we have some advisory panel members that are overseeing this work as well. We use the Joanna Briggs Institute framework for a scoping review, and from a transparency perspective, an a priori protocol is publicly available on the Open Science Framework. Next slide. So what is that JBI framework? Well, there are 9 key stages. Next slide. The first 2 stages are really about defining what the work is. And so in this part of the process, we developed some primary review questions. The question is in nutrition research studies, how are daily intake levels of low-calorie sweeteners in human populations assessed in the context of ADIs derived by authoritative bodies? And then you have to define the population, the concept, and the context. So the population that we're looking at is limited to humans of any health status, life stage, or sex. We define the concept as a comparison of ADI values to daily low-calorie sweetener intake. And then the context is primarily nutrition research studies. Next slide. And next slide. And then when we went through the literature, this is sort of the bulk of the work, we identified through literature searching almost 2,000 different journal articles that met both the population, the context, and the concept. However, almost 1,500 of those were excluded. The primary reasons for journal articles to be excluded is that they didn't actually estimate intake, or they were irrelevant populations, such as experimental animals, or the low-calorie sweetener was not assessed, or it didn't actually relate to our study objectives. For example, analytical wastewater quantitation. So when you look at the almost 2,000 articles and you exclude those that didn't meet the criteria for inclusion, we're left with a little over 200 full-text articles to review. Of those, almost 95 were excluded, again for those same reasons that we talked about, including 20 texts that weren't available in English. And that left us with 121 articles. When we looked at those articles, we classified those into directly relevant research and contextual research, which I will touch on in just a moment. Next slide. And next slide. Oh, then we summarized the evidence in relation to the objective and the question. Next slide. So with those 121 studies, they compared the intake of LCS to the ADI in some capacity. One of the things to understand about this work is that this is a very heterogeneous evidence base. There's a huge variety of study designs, of objectives, of really why the researchers were doing the study. So we split the 121 articles into directly relevant studies and contextual studies. For it to be considered a directly relevant study, it actually had to include a comparison of an original intake estimate or a controlled exposure to an ADI. So for example, this is really what we're calling primary research, and there were about 50 articles in that group. The remainder of the articles, or almost 70 articles, were contextual. And these inform part, but not all, of the research question, and they were primarily based on secondary research, such as reviews of intake studies, safety data, or how ADI is derived. Next. And one more. And this is, when we went through each of these full text reviews, this is just an example of the type of data that we collected. And more data was charted and collected to the directly relevant studies as compared to the contextual studies. Next slide. So here's some of the key results. So when we look at the types of studies and the types of sweeteners, low-calorie sweeteners that were studied, aspartame, and one more slide for me, Marie. Aspartame, Aspartame was the first and most frequent low-calorie sweetener compared to the ADI. You can see that almost 24% of the total studies were related to aspartame. Saccharin, acesulfame, and sucralose were the next highest ones. And then some of your newer sweeteners, they are beginning to be studied, but they're not highly present in the public or in the scientific literature as of yet. Next slide. It's also interesting when you look at the publication frequency by year. So 1987 is on the left. There weren't really any publications prior to 1987. 2018 is on your right. And you can see that most of the sweeteners are studied sort of throughout this time period. Obviously, as new sweeteners came on the market, that's when you will start seeing those. But in research interest and publication has really started to increase in the 2010s. Next slide. In addition, this research does have a global geographic distribution. Most of the studies have been done in the U.S. and in Western Europe, but there are many other parts of the world that are represented in these studies. Next slide. And so this is some of the key information from the work, and really it speaks to how ADIs are being used in current research. When we map the direct studies, they really map into 4 different categories. It maps into the overall goal of the study. It maps to the population of interest health status. It maps to age. And then it also maps to the context, how they're actually using it. And there are a lot of relationships between categories. So if you go forward one, we'll walk through the data a little bit here. So if you think about the type of study that was conducted, there were 4 main study types that were conducted and represented in this literature work. One is an exposure estimate, so just determining how much low-calorie sweetener was being consumed. About 20% were really looking at safety or adverse effects associated with consumption of low-calorie sweeteners. And then we also have metabolism studies and risk-benefit analysis studies. Next. When you look at the types of health status that is represented in this literature, by and large, the health status is a normal population, but there is about 25% of the literature that is addressing certain types of health status in the population. And next. And then we have our age distribution, where most of the research is an all-age comparison, but it contains a fair amount of adult comparison and school-aged to teen comparison. Now, you look at all the lines in the middle, and this is the context So if you think about the strength of the line indicates the strength of the relationship, the number of studies that we're doing it. So the boldest line on this graph is an exposure estimate in a normal population that addresses all age. And then you can see sort of how they're related in there. Next. And one more. There we go. So then you think about the 4 types of studies that we talked about, and we're going to focus on the inner ring in this circle first. So we talked about the exposure estimate with most of the study, and then health outcome work, metabolism work, and benefit risk analysis work. And then when you compare that to the outside, obviously your exposure estimate work, the primary type of ADI comparison for that work is an EDI, or an estimated daily intake, to that ADI, that acceptable daily intake. And then when you look at like your risk and benefit analysis, it's the same. It's an EDI to ADI comparison. But when you get over into your health outcomes and your metabolism, it changes a little bit. With your health outcome, with your metabolism work, there's really not an EDI to ADI comparison. It really focuses on using an ADI to justify an exposure level or a dosage level, or an effect level compared to the ADI. In your health outcome, it's very similar. It's really looking at an effect level. So what type of health outcome was being investigated, and how did their exposure to LCS with that health outcome compare to an ADI? Next. So overall, the things that we found were that intake and exposure studies really represent the largest portion of evidence base related to our research question, as well as those most consistent with the directed use of ADI. So for example, this is standard practice when you determine margin of safety. So if we think about our first speaker today, she talked a lot about determining that margin of safety. So much of this research evidence is directed actually towards that. You also have to think about the metabolism, and the health effect studies are looking at adverse effects. These studies utilized ADI in a manner that was reasonable to the context of that study, but they actually don't represent a standard application of the ADI. So for example, these studies were comparing no effect levels or dosage justifications. So these types of conclusions, as well as others that don't consider that representative daily intake average, should be interpreted with caution. So remember at the beginning, we talked about that appropriate use of an ADI, because an ADI is really about the lifetime intake. When you think about these studies that are talking about single day exceedances, or a short period of window, say a teenager from 15 to 18 in their intake, that is not, it's okay to exceed an ADI for a period of time, because that can be averaged out over the lifetime, because as you go through life, you eat more of some foods and less of some foods as you go through life. If we all think back to when we were children, we loved the sweets, we loved the candies, and now as adults, most of us don't find the sweets and the candies quite as pleasing as we used to. I also know that things like salt, you may not eat as much salt as a child, but as you get older, you have a preference for salt. The same thing's for bitter foods like coffee. You don't prefer them as children, you do as adults. And so when you think about how these EDIs, these exposure estimates, are really being calculated and determined primarily through review and survey and health, nutrition and consumption history, they're typically isolated to shorter periods of time. But when we think about how you're using the ADI, and particularly how you're recommending low-calorie foods to be used in practice, we have to think about the real application of the ADI is over an entire lifetime. And so a single point in time shouldn't be as much of a concern, because it should be averaged out over the lifetime. Next, Marie. I think that's the end. Oh, So while most instances of ADI comparisons are based on a reasonable approach, so they're using the ADI correctly in the studies primarily as a benchmark, it's important to understand that LCS intake should be interpreted appropriately relative to those ADIs that are developed by the authoritative agencies. That's that it should be used over the entire life, that you need to think about intake over an entire lifetime and understand that it can be used for a shorter period of time as a benchmarking, but we're really talking about over the lifetime. Next.
Great, thank you, Jennifer. So today we've received a lot of information on several different aspects of this topic. And we have a final presentation from Dr. Deepa Handu, and she's going to tell us a little bit about how this information can be useful to practitioners, either in nutrition practice or medical practice. And by way of introduction, Dr. Handu serves as Senior Scientific Director for the Academy of Nutrition and Dietetics Evidence Analysis Library. She has methodological expertise in conducting systematic reviews and quantitative analysis in the field of nutrition. In her position at the Academy, she's led the development of a number of systematic reviews and clinical practice guidelines, and has conducted research to improve evidence-based methods for the Evidence Analysis Library. Dr. Handu has delivered numerous professional presentations at the local, state, and national level. And with that, I will turn it over to you, Dr. Handu.
Thank you, Marie. Can you hear me clearly?
Yep, loud and clear.
Okay, great. Thank you so much. And we are right at the end, so be patient. It will be a quick presentation. My disclosure is that this presentation reflects my knowledge and expertise in the field and not the organization that I work for. Next slide, please, Marie. So when I was asked to present on this topic, I started thinking from the practitioner's viewpoints that when I'm counseling to patients, what do I really need to know? And the things that stood out was safety. ADIs are basically safety, which you have been listening to for the last 40 minutes, the effect on the health outcomes. Is there any scientific evidence? And then thinking about how do I take this information and talk to my clients. Next slide. Next slide, Mary. So low-calorie sweeteners, they're thoroughly tested and they're carefully regulated by FDA in US and Health Canada in Canada for approval to use in foods and beverages. As it was mentioned by previous speaker, ADI is the amount of ingredient that a person can safely consume every day over a lifetime without risk. And it is extremely conservative number. So to make sure that there's no chance of harm. Next slide. This slide, the next slide that Marie will move on to, just shows you a list of all the approved, low-calorie sweeteners in US. Next slide, please. So nowadays, low-calorie sweeteners are widely present in foods ranging from grains and dairy products such as breads, yogurts, and condiments. Also medications, personal care products like toothpaste, and many other foods and beverages which are not marketed for weight management. So the biggest key is that even though these products are not marketed for weight management, always look for the ingredient list. You might somewhere see a sneaky name of LCS, so be familiar with those names. Next slide, Mary. At present, based on evidence, low-calorie sweeteners are safe and they're approved by the regulatory bodies. There are some of the most researched and studied food ingredients. However, the long-term effects on human health are still very conflicting, and the evidence on young children and adolescents is still pretty murky. Next slide. So this slide just shows you the current state of evidence in this field. And as you can see from these bullet points, it is really very conflicting. The evidence from cross-sectional and prospective cohort studies suggests that the non-nutritive sweeteners or low-calorie sweeteners use is associated with increased body weight, whereas on the other hand, evidence from RCTs suggests that non-calorie sweeteners are used as beneficial for weight loss. The things to remember is that cross-sectional and prospective studies, however, most of them are based on self-reported data and the other confounding factors are there. So maybe those are influencing the results. Whereas in the RCTs, which occur in a very, very controlled environment, we cannot generalize the findings to the free living people. So we are kind of not very sure about this evidence and how it's conflicting. Also, evidence from systematic reviews and meta-analysis is mixed. Remember, systematic reviews and meta-analysis are only as good as the original studies that are out there. And most of them, they will reflect the findings of the methodology of the original studies. And another thing to keep in mind is that most of this discordance in the findings may be due to a number of other factors like study design limitations, challenges in interpreting the findings, what population is being studied. One of the most ignored fact in most of these studies is something called potential for adverse effect modification. That means people who are already consuming an unhealthy diet and then you're studying them for something else, there has to be some effect of that. There's also the concept of reverse causality. That is, association between sweetener consumption and weight gain can be because individuals who are already predisposed to obesity consume more sweeteners in attempts to prevent weight gain. So that could have some reverse causality. Then also in these studies, there's always room for confounding factors. As everybody who knows nutrition field, it's very, very nutrition field. The literature is very fuzzy sometimes. So there are some unmeasured, unexplained factors that can mediate or moderate the relationship between the sweetener consumption and these outcomes that we are interested in studying. And that's called residual confounding factors could play a role. So there's a lot going on in this field of research, which makes the evidence a little bit uncertain or very conflicting. Next slide, Mary. There are many organizations out there that have developed guidelines in regards to low-calorie sweeteners. There's a list of a few over here. They all have a little different take on the message as they address different populations. Some are made for general population, some are for people with comorbidity conditions, children. And so their approaches also are very different when they develop these guidelines. But the bottom line by all of them is the same. It's just a little bit of a different take. Next slide. The Academy had 2 guidelines published, and their guidelines are based on systematic reviews, one of them in the pregnant women. And what they say is that in pregnant women with gestational diabetes who choose to consume these sweeteners, the registered dietitian should educate the patients to select only those that are approved or considered safe by the FDA, and also limit the intake to ADI. So basically, if you are choosing the ones that are considered safe, and if they are within the approved limit of ADI, then you should be okay. Next slide. And in individual with diabetes, it's a similar kind of, the message is same, safe if consumed within the recommended ADI. But another thing to remember is that you should also educate them then to make this a part of their full diet. If you look at the second statement, the second guideline over there, the dietitian should educate adults with diabetes that substituting food and beverages containing FDA-approved sweeteners within the recommended daily intake levels. This can reduce overall calorie and carbohydrate intake. However, other sources of calories and carbohydrates in these foods and beverages need to be considered. So the use of non-nutritive sweeteners has the potential to reduce overall caloric intake, but if substituted for caloric sweeteners without compensation by intake of additional calories, people forget that even if you make this change, it should be a part of your total dietary intake. It's not an isolated thing. So keeping your overall dietary pattern in mind is very important too. So guide them on that. Next slide, please. While the science behind non-nutritive sweetness is important as part of how RDNs should prepare themselves to help their clients, also understanding how they function and how their taste can vary can help one guide patients to an appropriate choice. So work with your clients. Not everybody likes the same sweeteners, and there's a reason sometimes when you heat a sweetener, or if it's used in a baked product or a cooked product rather than a beverage, there's a difference in the taste flavors. So work with them and figure out what works the best for your client. Next slide, please. The take-home message from this slide over here is, please do not base your opinion on one single study, the single study syndrome, which is very common in today's day and age. When everything gets published on internet and there are tons of people talking about it, you kind of go and you get swayed by what is written. So please keep in mind, don't get affected by the single study syndrome. Most of the guidelines and the recommendations that are developed, they are not based on one single study. They take into consideration in tons of research and then come to a conclusion. Okay. Also, critically evaluate the study of the day if you're going to follow or read somewhere something. Key things to look for is whether it's an animal study or a human study. There is a difference between both those studies and how the sweetness preference is different in both of them. Also look for the population of the study. Is it conducted in healthy people, overweight people, or people with diabetes? There's a difference between epidemiological and clinical trials. So we touched a little bit on them, but always paying attention to those things. Another big thing is the dose of the low-calorie sweeteners in these studies. What has been noticed in the past is that these studies have been supplementing way over the ADI doses, and which is not the norm or which people might not be doing. So be cautious to that when you read a study. Also look for studies if they're trying to present treatment versus control comparisons. Majority of the studies in this area do not report these differences. So they're not making the correct comparison between the groups. So keep your eyes open for that. Critically vet a study before you take a stance or just follow what's written in the media about that study. Next slide, please. Some other things to take into consideration when you're working with clients is, if your client has diabetes, looking at the blood glucose responses, looking at the nutritive values, sweetness, the ADIs, and everything else. Work with your client, individualize it. There is no single message that works for everybody. So take their opinions and their interest in consumption into consideration while counseling them. But these are some key things that you should keep in mind when you work with a client. Next slide. If someone has increased desire for sweet intake, replacing some of the high sugar foods with low calorie sweeteners can be really helpful. Okay. Also, something to educate or discuss with your client is that although many products in the marketplace use artificial sweeteners, it doesn't mean that the product is completely calorie free. I think this message needs to be sent out over and over. In addition, sometimes a product that uses artificial sweeteners still may be high in fat, saturated fat, or salt. It's still essential that people read the nutrition label before they buy any particular product. And also talking to them that it always helps to be consumer savvy. These low-calorie sweeteners can help with weight management, but they're not the magic bullets. Moderation as it applies to overall diet should also be applied to low-calorie sweeteners. So if you're still wondering after an hour of a talk provided by all of us, whether you should recommend non-nutritive sweeteners to your patients and clients, I think all I can say at this time is, at this time, we don't have evidence that allows us to put limits on the consumption of LCS. However, for certain groups like children and adolescents, young adults, we know that the research is lacking. So work with your client, okay? Be individualized. Do not get one message out to everyone. They are safe alternatives to sugar, which may be appropriate, for individuals who really need to restrict their dietary concentrated sweet intake. So work with each individual in a little different manner, what works for them. And that's all I have from my side. Thank you.